Hi, good morning, everyone. My name is Brinley Brooks, and I am the founder of HS Connect. And I am here today to talk about wound care with you all. Today, we have also Katie joining us, and we'll give a little intro on her as well. Our main speaker today is going to be Dr. LevTov, who is currently the associate professor at the University of Miami and is very active in the field of HS research and treatment, as most of you probably have heard his name. Dr. LevTov grew up in Israel and was always curious about science and loved helping people, so medicine was a natural fit for him. And once he was in the field of dermatology, he could not think of a disease that needed more attention than HS, so here we are. He also has some knowledge about wounds and wound care that he brings to the HS world and wishes to share with us all. His hope is that we can have dedicated solutions for HS in the coming years. And today we also have Katie Sherling joining us for the Q&A portion of the session as well. And Katie is an ARNP and certified wound care advanced practitioner. She works full-time in wound care centers and has been treating wounds for nearly 10 years. I was lucky enough to have Katie and her team treat my wounds after wide excision surgery, so I know them personally. Katie is passionate about the care of HS patients because helping us learn and understand how to treat our wounds empowers us as patients. This will be fun. Don't forget, this will be available to rewatch afterwards in case you missed something or need more info. Please go ahead and make sure you put your questions in the chat as we're going through so we can cover as many of them as possible in the Q&A section. And thank you again for joining us. And we're going to go ahead and introduce Dr. LevTov, and he will take it from here.
Hey, really, Katie, thanks for the introduction. Hi, everyone. My name is Hadar LevTov. I'm going to be trying to share my screen here as we go through this. I am an assistant professor, not associate professor, but thank you so much for promoting me. This is fantastic. And I am coming to you live from Miami. A bit chilly here today, but definitely we consider upper 60 to be chilly. So today I'm going to talk to you about wound care for people with HS. And, you know, this is where I am. This is where I work. This is the University of Miami, the entire medical campus here. And usually I'll see patients here as a dermatologist. And, you know, they say about us dermatologists that we make sometimes rash decisions. But I'm definitely trained in dermatology as a board certified dermatologist. But also, I do a lot of work in the wound center. And definitely the University of Miami is known for its expertise in wound healing. Our entire department, which is located here, has many labs researching wounds. And what I was hoping to do is to bring together those two fields, because definitely there's a need, and HS is a great example where the science of skin and science of wound healing definitely meet. But between being in clinic, being in the department, I think all of us wish we were down there in Miami Beach. Hey guys, surf looks good. Couple of disclosures here that I wanted to make. So I am a founder, and I hold stock in this educational company. I also have a podcast, and I'm also running clinical trials and work with industry in the wound healing arena, and as well as HS, trying to investigate and bring the best intervention for patients. And we may discuss some off-label use of treatments as we go through, but the most important thing I want you to take from this is I do not endorse any specific dressing for HS. Part of it because I don't know that there's a single one that's the best. So just keep that in mind as we go through this. I like to start with the bottom line first, and that is a few things that I want you to take away from this talk. First, people with HS may need wound care. It may not be everybody. It may not be the conventional wound care that some people think about, but definitely wound care is needed. And HS is managed by a big group of healthcare professionals. So some of you have interacted with dermatologists, some with surgeons, you're a gynecologist, even a colorectal surgeon, a nutritionist. And within all that group, there is a specialized group of people that deal with wound care. Unfortunately, there's no real specialty like that. So in wound care, you may deal with a nurse practitioner, you may deal with an MD, a DO, you may deal with a podiatrist. You never know who's going to be that person, but usually they have decent knowledge about wound care. And the point is that usually those people are found in a wound center or a wound clinic, and that is not your normal dermatologist or surgery clinic. And so the best thing you can do for your wound care is to find a wound center near you, because these people are experts in getting the right dressings to you, help you manage all the aspects of wound care. And speaking of that, getting to the bottom line first, dressings, which is where those wound experts can get you, dressings absolutely matter. And until recently, we didn't know it for a fact, but then we just published a study, and I'm so excited, I want to share it with you. It's a bit of raw data, and I'm sorry I'm putting a graph. It wasn't the first slide, but I'm putting kind of a graph, but I promise it's not going to be too complicated. Suffice it to say, if I understand it, then definitely you guys can follow. But basically what we did is we took people with HS, regardless of what treatment they were on, and just gave them dressings, just gave them good dressings to use. And hopefully people can see my pointer here, but we measure their quality of life. This kind of DLQI is basically a shorthand for a score that suggests how good or bad their quality of life is, with 30 being the worst and 0 being great, meaning that the disease does not interfere with your life. And here you look at the baseline, the visit 0, people with HS, as we expected, had really not so great quality of life. You can see here the score between 11 and 20 suggests that there's a very large effect on the patient's life. So people were kind of hanging out around here. And then within 2 weeks of using good dressings, they were actually able to lower that aspect. You know, the effect may have dissipated a little bit. It's an average effect. There's so many things moving when you manage HS, as you guys know better than I do, but definitely we can make an impact just with good dressing. And so what we concluded is that we want to make HS dressings available, wound dressing available for people with HS. What we fashioned is a bit of a starter kit, and that speaks to the point that there's no perfect dressing for HS-related wounds that will solve everything. As you guys know better than I do, HS is a different disease on a given day in a given site, meaning anatomical location. If it's in the armpit, it's different. If it's under the breast, it's different. It may be different today. It may be different tomorrow. Maybe some people are on their cycle and now it acts differently. Maybe today it's a big bump. Tomorrow it's an ulcer. Today is an abscess. Tomorrow is a tunnel. And so it doesn't even make sense to think about one dressing that will fit at all. However, if you give the right selection of dressings and give people a chance to actually use good quality ones, then you can make a big difference. And so we hope that in the future, we'll be able to do better, larger studies to actually figure out which dressing for which part of the disease. Okay, so what I'm going to talk to you today is basically give you some basic tools to understand how to approach wound care. So when you talk to the doctor, wherever you're going to be, you are kind of well-trained and well-versed in what wound care products are available and may be helpful for you. Okay, so this is kind of overall of the treatment paradigm, the way I kind of see it. And when I talk to patients about HS, they really talk about it as the devil, something evil that's just been, unfortunately taking over their lives, preventing them from doing anything that will make them feel better, get a job, finish college, anything like that. And so people really treat it as the devil. And so there is a pathway that starts with good disease control, and that is medical control, which your board-certified dermatologist is usually the person that can help you get at least some of the disease burden off. And there's some adjunct therapies that you're aware of. And then many people are good candidates for surgery, and usually when you get surgery, a lot of times that's a very good definitive treatment that can take you to that promised land for you sitting on the sitting on the beach, sipping some beer. But that process, right, can take years. And many of you are probably somewhere in the middle. You've seen a doctor, you read something online, you started some kind of medical therapy. You don't even know about surgery. You don't even know if you're a candidate for surgery. One thing is for sure, you are somewhere here in the middle. And the question is, what's happening in the middle? How do we treat HS? And I'm going to argue and tell you that I think that something in the middle is what we call wound care. Because between taking a pill, injection, whatever you're doing, nutritional intervention, yoga, you name it, you have to take care of your skin. There's drainage, there's pain, there's open wounds, and you got to live your life. And so wound care becomes this enormous thing that becomes a part of your life. And I came up with a concept of how to help you remember and how to help doctors remember what kind of issues you need to deal with when you are thinking about what kind of wound care to select for yourself. And we're going to go over this in detail. But one thing is colonization, which I'll refer to, basically means there's bacteria in the wound. They're not causing a problem, but in the sense of an infection, right? You don't have necessarily fever, enormous amount of pus coming. It's not red and tender. Sometimes it is, but there's no systemic event happening. So basically bacteria sitting in the wound, we call colonization. Exudate, which is basically the drainage, the fluid coming out of the wound, the tunnel, you name it. Odor, no need to explain what that means, but a lot of people with HS are really poorly affected by odor. Even though I can tell you as a clinician, a lot of times I don't even smell it, but patients definitely complain about it and we want to address it. And the last thing is pain, which you had a dedicated talk, but I'll just give an example on how selecting dressing can sometimes help with the issue of pain. And because it's hard to remember and because I'm a bit of a child, I put this together into a term called COPE. So between getting good medical care and maybe getting surgery, you guys need to be able to cope. You need to cope with HS. And I want to remind you that this is kind of my philosophy, but I think it's a good tool. So let's go through these quickly in the next few minutes and try to understand and hopefully give you basic tools how to talk to your doctor, how to investigate or even shop online for things that you need. So disease control is the first thing. And I think it goes without saying that if you don't treat the disease, the wound will not get better. There's no way around it. Everything we're doing in a wound care arena is really an adjunct. It's just an additional thing to kind of help you get through it. But if you're not solving the problem, you're just putting a Band-Aid over it, pun intended. And so the first thing you want to do is identify a good provider like a board-certified dermatologist that can help you medically treat this and get the disease under control, okay? So now, if your doctor is not aware of this, then let me put here a plug for the HS Foundation, a great organization. And through this link, there are the North American Clinical Management Guidelines that have been developed by experts from both the United States and Canada. And so they're more relevant to the interventions we have here in the US as opposed to the European guidelines and others, okay? And so this is a free download, and feel free to go down there, print it out, and give it to your doctor because you want to get the best medical treatment that's evidence-based, and state-of-the-art evidence is right there. And by doing that also, maybe they'll get to know the HS Foundation website. So definitely educate your doctor, get good medical care. That's the first step of any wound care for HS. All right, so now let's talk about colonization. And here, I want to share with you some findings of studies that you may have heard about before. But turns out that when you look at the bacteria that live on the skin of people with HS, well, they're different than people who don't have HS. So it's probably not shocking to most of you to know that you are a minority in your own skin, right? You have bacteria covering your skin, covering your gut, and they outnumber you by far, maybe by 100 times in terms of DNA quantity. And there is now some evidence that different diseases of the skin have different microbiome, that family of bacteria that live on your skin. And definitely what you see here, this kind of colorful, beautiful graph, basically the investigators look at the composition of bacteria on the skin of people who don't have HS, here the healthy control on the right, and then people with HS, be it on the healthy looking skin or the lesional skin where the disease was. And the bottom line, and you can tell already, that even though there's some similarities, like this is type 1, right? Type 1 microbiome. So a lot of people had similar microbiome, type 1. There are some differences. As for example, if you look at type 4 that has a lot of this dark green color, right? These patients have these kind of bacteria, which you can read the fancy schmancy names down here, were not on healthy control. And the bottom line of it is that even though a lot of the microbiome on your skin is similar to maybe your friend or your family member who doesn't have HS, a lot of people with HS have differences. And that is thought to play a role in how the disease progresses. Not only that, there was other evidence that showed that sometimes biofilms exist in the tunnels and lesions of people with HS. What are biofilms? So that's when single bacteria get together in a neighborhood. They build a fort around them and literally are much stronger together. And when you give them antibiotics, basically they say they play dead like possum. They go to a low metabolic rate. They sit there under their cover and wait for the antibiotics to go through. And when the antibiotics go away, they wake up, they're metabolically active all of a sudden, and they start, causing problems. And this colorful picture shows you these little green dots here that show you that in HS you definitely have these biofilms. And when I think about HS, I really think that a lot of times we give antibiotics, right? You get better, and then you stop the antibiotics, and then you get worse. And that's a classic feature of diseases that have biofilms, and it exists across, not just in dermatology and other fields. And so with this idea in mind, we have different bacteria that we need to normalize, maybe bring back that microbiome balance. And we have maybe biofilms that are in the tunnels. We need to think of what can we do about it. So definitely when it comes to wound care, we can help. So you may get antibiotics and all kinds of other debridement, but really there are dressings now on the market that can really help with that. And I put here an array. I don't endorse any one of those. I just wanted to show you that every dressing that you can think of nowadays come with various antimicrobial interventions. So you see here those green ones that have this molecule that helps to pull the bacteria out of the wound. And you see the purple ones, which is gentian violet with methylene blue. And one of the most available agent is silver, shown here on the right. So usually it's either color silver dressing or just plain black. Silver is probably the working horse in a wound clinic in terms of antimicrobial, and it's very good. You can actually get some sheets now that have silver on it, and if you want in the Q&A, I can elaborate more. But definitely, a lot of dressing can come with antimicrobial agent already into it, so it's a one-step, very easy to do. There's also a group of products on the market that are surfactant-based. And what's good about surfactant, it works like a soap essentially. So it's showing you here that it's made of a little ball of surfactant molecules, and they have a part that's afraid of water and a part that loves water. And so what it does, it basically will, this ball will cover a microbial entity and kind of pull it away with it. And what can it do to a wound? Well, we don't have good evidence in HS, although I promise you by this time next year, God willing, we will have, because we're working on a project right now about this. But here's a picture from one of my wound patients in the clinic. And you can see here that there's a wound that's been there for a while. And on day 0, it has all this, what we call slough. It's just basically a bunch of muck on the wound, a lot of bacteria, probably biofilms, well, for sure biofilms. And you can see that just applying this gel really helps. So surfactants may be helpful. Here's another example of those green dressings I mentioned to you. This dressing, as shown here in the picture of a patient with HS on the buttock, really can help to use hydrophobic forces to pull the bacteria out. Now, what I like about that, conceptually at least, is that it doesn't kill the bacteria in the wound, because when you kill bacteria in the wound, you increase inflammation, and HS is an inflammatory disease. We don't want to increase inflammation, so we'd rather just kind of take the mess outside of the wound and let the bacteria die in the dressing as opposed to inside your skin. And we definitely have done some work with this, and those are the dressings that were used in the study I showed you originally. So we have a cumulative evidence, although we don't know that it's necessarily the DAC part of it, the green component that really worked. It may be just good dressing. Let's talk about odor. No question that odor is a problem in HS. As you can see here in this study that was done by one of my colleagues, Dr. Alavi, they looked at what happens with odor and if it can predict the quality of life in HS. And as you can see here, it really predicts it nicely. You can see that the patients, if you look at the severity of quality of life, remember I showed you in the beginning, we can measure quality of life in different measures. Here they used a different measure, but you can see that in that measure here, people who perceived to have high odor had worse quality of life. People with low odor had better quality of life. And that persisted throughout the aspects of the survey. So definitely a big problem that we are coming to recognize. The question is, what can we do about it? And the issue of odor is not new. Ignore this busy table for a second. I'll tell you what I want to show you here in a second. The idea of odor is not new, right? People with wounds have been suffering from bad odor for years. And unfortunately, the main problem is that it's a very difficult topic to study. Why is that? Well, because we don't have an electronic nose. The way this has been studied, and I'll show you this here, if you look at the odor assessment column here, you can see here right in the middle that it was basically a visual analog scale or visual numeric scale. Basically means that someone walked in the wound, smelled it, like wine tasting maybe, and said, okay, 0, okay, 9, okay, 5. And that's really not the way you want to do science. But this is the evidence we have, and this is a review we did a while back on various studies that look at wound. So that gives us a clue as to what can help. So you can see here already that the type of wound are not HS. A lot of them are malignant wounds, some of them diabetic foot ulcers, and the next slide I'll show you others. But it helps to understand that you can use antimicrobial. Here, metronidazole gel has been used the most, and it really can be helpful. You can see that silver can help, and you can see that absorbent dressing, which basically handle a lot of exudate and probably reduce the amount of bacteria in the wound, are also helpful. This is kind of the continuum of that. This is using honey versus silver, and basically all these interventions are essentially antimicrobial effect. And so if you have a good antimicrobial agent, a lot of time you can handle the odor. All right, let's go and talk about pain to continue with our COPE acronym. So this is data from the best study ever done on HS, and those are the pioneer studies that led to approving adalimumab as or some of you know it as Humira, as a treatment for HS. And this is looking at these people. You can see already that they had a lot of patients in the study, so about 300 here, 320 here, and they used this evaluation of pain, and you can see that about 85% of people with moderate to severe HS had moderate to severe pain within the last 24 hours. I mean, this is just, the mind boggles. People walk around with so much pain. So our wound care can help for that. Definitely treating the disease, reducing the inflammation helps. But some of wound care choices you can have are helpful. So here's a category of dressings. And in the next few slides, we'll talk about categories of dressings, not a single brand. I try to put a few brands from each category. So, you don't think I'm endorsing one or that one is better than the other, because we don't know. But conceptually, they should help. So one on the right here, well, let's start on the left, because that's something you may be very aware of. These are non-adherent gauze or non-stick gauze. These are gauze dressings that basically don't get stuck in the wound. They're not woven like the regular woven gauze. So that can help a lot of times because it doesn't stick to the wound, to the tunnel, and really can help when you change dressing. On the right here, you can see one of my favorite dressing ever, okay, for any wound, and those are the contact layer. You can see here that it's basically a mesh. It's an inert mesh that sits on the wound as a primary dressing, meaning it's the first thing that comes in contact with the wound. And then you can change on top of it whatever dressing you want. If today you have a lot of drainage, put a very absorbent dressing on it. If you don't have a lot of drainage, put a less absorbent drainage on it. But this protects the wound, and when you change the dressing, it doesn't hurt. There's a few brands on the market. They're called contact layers. Love them. All right. Another intervention that can potentially help is something called hydrogel. Now, hydrogel, you may know, comes either as the gel itself, as shown here in a bottle here or in a tube, but a lot of times it can come as a sheet, as a dressing. And so I put a few of those. And definitely there are many, many, many different brands that have in their kind of basket of dressings that they offer. They also offer you the option to use hydrogel. Hydrogel has a very soothing effect on the wound. And we found that at least anecdotally with some of our patients, they really like that. So hydrogel dressings can soothe the pain. All right, we're switching now, talking about exudate. If you see the little purple oval on the left here. So we are rounding up our issue of COPE, right? So we talked about colonization, odor, pain, and now exudate. And those are the four things you're going to tell your doctor how to choose your dressing. So let's talk about exudate. Definitely a big problem, all right? You're sitting in a board meeting, you're sitting in class, you're in your job, wherever you are, just hanging out with friends, and all of a sudden you feel like, oop, there's a drop in the armpit. Oop, there's something coming down. right? And so the question is, how can you be prepared for it? And the good news is that when it comes to the wound healing dressings that we have, Exudate is the one thing that we're doing really good on. There's a lot of dressing selection to choose from, and there's a lot of brands on the market, and I'll try to put this in simple order for you. One thing to note is that a lot of time cost is the issue. All right, so we'll start with the most absorbent. These are a class of dressing called super absorbent, and they are built, if you look here, this is a schematic of one of them, and you can see how extensive the technology is. So you have multiple layers. Here you have a wound contact layer. Remember I told you about contact layer? Here it's already built into the dressing, right? And then there's a distribution layer. These dressings are so smart that even if you have a small tunnel and the dressing is huge, it's going to take the fluid that comes out of the wound and really spread it evenly across the dressing so you can get more mileage out of it. You can use it for longer. And then what makes these dressings different is they have here a super absorbent layer, and that layer can actually swell sometime with the fluid coming in. It can really handle a lot of fluid. And finally, it's covered by these this semi-permeable membrane, or basically kind of something like a tegaderm, like a film dressing that sits on top that helps keep the exchange of oxygen in and out. And so it helps to maintain an occlusive environment. And so these dressings are really powerful, but as you can imagine, they're not cheap. Just look at the technology going into them. So super absorbent, those are for the really leaky wounds that you just can't finish 3 hours without changing a dressing. The next category, and almost just as absorptive, are the gelling fibers. And those maybe, they're very, very good. And some of you may recognize some of the brands here. They are also a working horse in a lot of clinics, and they basically work like diaper technology. So they have these fibers inside that when they come in contact with any fluid, they immediately turn into gel. That's what they're called, gelling fibers. And so from the fluid turns into something solid that stays in the wound. And they come in various shapes and forms, and you can actually see that some of them have silver on it already, right? So the AG here stands for silver, as I mentioned to you. So that's a twofer, right? You put this dressing, it handles the exudate, it handles the colonization. Hey, if the bacteria there are a leading cause of odor for you, maybe it's going to solve the odor as well. And for those of you who had surgical wounds, sometimes, I'm not a big packer, but sometimes you need to pack a wound. Some of these come in as a packing material. So definitely great dressings to help with your exudative wounds. Then we have other very absorptive dressings. Those are the ABD pads, abdominal pads, which you'll probably get from your insurance. They are good, but they're very bulky. So, that's the trade-off. Calcium alginate, very, very absorptive, but sometimes not strong enough. Sometimes it breaks down and gets stuck in the wound, so it can lead to painful dressing changes. If your insurance covers that, and they do a lot, then use, remember I showed you the contact layer, use a contact layer under it, and then the fluid will come to the alginate, but the alginate will not break down into the wound. All right, foams, we're almost, this is kind of the last category almost of dressing. Foams are also very good. Probably the most common dressing covered by insurance are foam dressing, and those are the workhorse in a lot of our clinics. They are absorptive to an extent, and they're just more available. So I think it's worth starting with those and kind of see where you're going. For those of you who underwent surgery, you know that another way to handle exudate sometimes are negative pressure dressing, and they help. For those, for some of you, now companies took this technology, and it's a portable negative pressure system. So it helps heal the wound, and it can control some of the exudate. But it does involve wearing like a beeper on you the whole time, something that kind of goes bzzz the whole time. So most of my patients don't love it. All right. Finally, remember, you want to try, if you can, to excise out the bad tissue. Here, I just put briefly to show you what normal skin on the left looked under the microscope, and you don't need to be a pathologist to see that something's gone wrong here. On the right, there's a lot of these little blue dots in the middle of the picture. Those are infiltrate of inflammatory cells, a lot of inflammation. So, if you can, for the right people, cut it out. All right. Okay. So I'm about done here. I introduced to you the COPE principle, and really I want you to think about a wound center as the place that you need to go to deal with wound experts who can help you think through the dressings that are right for you. And I told you a bunch of categories that are probably the most useful. And we talked about selecting a dressing that can handle the most of these 4 principles: colonization, odor, pain, and exudate. And hopefully with that, you can cope with wound healing and HS just a little better. All right, I'm done here. I just want to thank my mentor, Dr. Kersner, and the nurses here shown on the right, on the left. Those are the people that really do a lot of the hard work. And if you want to learn more about HS, know that the HS Foundation is putting together the meeting in October in Miami. So come visit us. If you're curious about wound and you're a healthcare provider, the SOWC, I'll be speaking there. And if you want to learn about integrative approaches and you're a healthcare provider, then at the Integrative Dermatology Symposium, I'll be there as well. Thank you for your time and attention.
Hi, guys. Welcome back. Thanks for joining us after the break. Hopefully you got a chance to look around and interact with the sponsors and the organizations. So thank you so much for putting all of your questions in the chat. We're going to go ahead and cover a couple of those questions. And then we also put together some slides with some commonly seen wounds or wounds that we get asked about constantly in the community. So we're going to kind of be able to go through those one by one and take a look at them and ask our experts here what they would suggest for those kinds of wounds. So we know one of the number one issues we have is in the areas where there's so much friction, such as your groin or your armpits, or where it's really hard to bandage and keep bandages on. What do you guys suggest for those kinds of areas?
Yes, so absolutely, you said correctly, Brinley. This is by far the weakness of wound care in HS. So just a sentence background, just so you understand, wound care products have been developed for people who have wounds on flat surfaces, on the leg, on the foot, on the tailbone. It was not developed for people with HS. And if you can do anything from today, please make a big noise and ask the wound care companies to develop better dressings for that. I know I am. But with that in mind, a few simple solutions. One, try to avoid using tapes and try to use wraps to wrap it around, because that will keep it better in place. So you can get gauze wraps that are common, like gauze bandages that go around, and you can wrap it in different areas. If you're not sure how to do it, look up online what a gun holster looks like and kind of try to work with that, okay? I'm not advocating you should get a gun, but just look at the holster. There's also what you can do is use normal clothing, just buy them one size smaller. So you get a t-shirt that is one size smaller, and that can help to hold things in the armpit, or an underwear that's one size smaller. Buy the cheap one because you know you're going to need to go through them a lot. Now, to hold things, recently, we do have one product on the market. I'm not endorsing the product. It's the only one there. Interestingly, started a company from a person who has HS. So really, I love that woman. But this is called HydroWear. Now, data is still weak here, but it doesn't mean it doesn't work. It just means we don't know. And that system is available now on the market in the US, and you can ask your doctors or look up their website. And that basically allows you to put in dressing in this location and kind of holds it in place. So definitely something worth looking into. I'll stop there.
Katie, do you have anything to add for that?
Yeah, so we talk to our patients a lot about using feminine hygiene pads because there's adhesive on the back. And so like he was saying, if you wear a well-fitted t-shirt, you can take that feminine hygiene pad, remove the adhesive from the back and put it on the inside, of your shirt. So the adhesive sticks against the shirt there. And then as you close your shirt and put it on, it's folded nicely underneath. And there are a lot of different sizes and shapes to feminine hygiene products. They're designed for heavy flow or, for heavy drainage. And so they already sort of have that wicking technology built in. So I think women kind of have come up with that idea naturally, but when we suggest it to men, they're like, oh, okay.
Yeah.
And even using it in their boxer briefs, or women, we've suggested to women to wear boxer briefs as well, to find the right size for them and to fit those pads that have some adhesive on the back into their wear.
Yeah, that's a really good suggestion. And I actually personally only wear boxer briefs now. And it does make it much easier for adhering, bandages. And as far as the HydroWear, Dr. LevTov, I completely agree. I wish that I had known about that product a long time ago. Especially if you have a lot of drainage in your armpits, it may be a really good option. So we'll post a link in the chat to their products as well. And then, so if we can go to the slides, I think, that kind of covers, the other question that actually comes up with that is people who are allergic to adhesive. We suggest the same kind of things, I suppose, or is there another tape that they may be able to use?
Well, it is crucial to make a distinction to know if you're really allergic to something or it's just irritating your skin. So allergy is a true problem that only you have. Irritation is something that's going to happen to anybody if they kind of rub the skin enough, right? So how do you tell the difference? Well, take a piece of the tape, put it on your forearm here, cover it with something else for 2 days, and then look if you develop a reaction under it. That's a good, simple way to know if you're allergic. Now, if you're allergic, you should talk to your doctor and kind of see exactly, because it may be that you're allergic to other things as well. All right, so that's one thing. If it's an irritation, that means that all the intervention we mentioned before are helpful, and you can basically, the idea is to keep the friction to a minimum and keep the adhesives to a minimum, and we talked about that. So make that distinction and try to keep things dry. You can also use some barrier creams, and I think we may talking about this, but something like zinc is a good barrier cream, so you can apply that to reduce that friction and see if that helps.
From an adhesive standpoint, Dr. LevTov had mentioned like those bandages that are non-adhesive in the middle, and then outside there's an adhesive border, and usually those are pretty well tolerated. I think it's like the long wear, the reoccurrence of on and off, adhesive on and off, that really tends to irritate the skin. So avoiding, but some of the other tapes that we suggest to patients are, it's a foam-based microfoam. Microfoam is kind of what you can type into Amazon or ask your healthcare provider about. It's kind of spongy and tends to be comfortable on the skin, and when you remove it and have to reapply it, if you want to put creams underneath and then reapply, it tends to go down well. And then again, not promoting a specific brand, but NextCare is a common brand that you can find over the counter or at a pharmacy that has a blue tape, so it kind of stands out. People remember that. And it says sensitive, gentle skin. I think it comes on and off nicely. Does it hold very well? But it does seem to be pretty comfortable for people.
And I noticed when I would get irritation from bandages, I would try to change the size of the bandage that I use. So if I was using gauze, I would fold it a different direction so that I wasn't always adhering the tape to the exact same skin.
That's a good point.
Could try to kind of cover, go around it larger or smaller to try to give my skin a little bit of a rest. So I know that people can try that as well. So, okay, so now we'll go to the slides and take a look at some of the common wounds that we see. And caution, these are graphic. These are real people wounds. So if you get queasy, you feel free to look away, but I would encourage you to continue listening. We will kind of give you a play-by-play on these. All right, so the first wounds we have are pretty much the holes that we get left with. If we can move to the next slide. So abscesses post-drainage, most of us get stuck with these kind of holes that look exactly like this. And we get a lot of questions on what the best way to address these wounds is. So Dr. LevTov, we'll start with you and then go to Katie.
Yeah, I think it's variable. So, some of these wounds, I don't want you to think just because one thing looked like it's the routine thing that, there's a bit of a differential diagnosis here, to be honest. But generally speaking, it's more going to be about the amount of exudate. The wound here on the bottom that you see maybe a little hypergranulating, as was mentioned before, meaning that, wounds heal from the top, the skin tries to cover, and also heal from the bottom, filling in. And here, this wound is a little eager to fill it in and is not waiting for for the rest of the skin to cover. So we call that hypergranulation or proud flesh. You may hear that as well. So sometimes there's intervention your healthcare provider can do to kind of reduce that amount and allow the skin to go over. And then all the dressing we spoke about, I would choose here based on the location, based on the amount of drainage. And I want to note that you can see in the surrounding skin already that there's redness. And that suggests to me that there's some irritation, maybe allergy. I would argue more irritation, but we need more information from the patient as to what they used.
Yeah, all great points. I was, and it was a question like, what would I, as a wound care provider, suggest that they put on this?
Yeah.
I agree. It's always a caveat with pictures, and but just from what I can see, I agree. There's some degree of peri-wound irritation, so we might talk about some strategies to reduce that with a topical salve, perhaps like zinc is something that I love and recommend often. If zinc feels too heavy, then usually I'll just go to Vaseline, and then topically, if these are fairly close together, and again, trying not to put too many adhesives on the skin, I'll typically recommend some kind of contact layer if it's painful. And if there looks to be a bacterial load, that contact layer sometimes is antimicrobial. I do like that green, it's called DAC technology. It's the green contact layer that was shown in Dr. LevTov's presentation to reduce topical bacterial presence, and then an absorbent pad over that and held in place with whatever is comfortable. If a little bit of adhesive works for the patient, great. If we can get it to stay in place without using adhesive, that's always my preference. And then again, the amount of drainage. So if it's really excessive and there's an odor component, usually the patient wants to be able to change it fairly often. And so we do usually go with just an abdominal pad or ABD pad because it's inexpensive and can be changed out quite frequently. Again, leaving that contact layer in place for longer periods and changing the outer dressing more often. If it's something that has low to moderate drainage, then we usually will come up maybe with a silicone foam dressing because it's usually well tolerated in terms of adhesive, and we can kind of mold it to the skin and leave it in place for 24 or more hours. But if we can't get at least 24 hours of wear time out of a dressing, I'll usually, go with something that's more cost effective.
And really, I just want to jump in on that because Katie, I saw it come in the chat, and people wanted a list of dressing. And the reason I structured my talk the way I did is so when Katie just talked and said, I'm using this foam and I'm using this contact layer, you understand what she's talking about. Because the reality of it is that there are 100 different foams and maybe a dozen different contact layers on the market. And wherever you live in the country or on this planet, you may end up finding in your formulary basket a different kind of product. But it doesn't matter. All you need to know is a handful of categories. And then from that, you can work. So get a pen and paper. I'm going to read these categories after the next question, and you'll be much smarter moving forward. Go ahead, Brittany. Sorry, I just want to comment on that.
Yeah, no problem. Thank you so much for that. And we also have on HS Connect, I believe it was posted in the chat as well, but we do have a wound care guide that Katie and I work together on. And there's also a YouTube video of an interview that she and I did, and it does cover a lot of those things as well. So we'll have that in the chat, and you can take a peek at that as well and see if that answers some of the questions. And then next we have some other abscesses. It looks like one of them may be kind of on the verge. It's under the breast. And then we have one on the inside of the thigh, which actually belongs to my daughter. And one of the things we were talking about is that sometimes those smaller abscesses can hurt even more than the larger abscesses, which seems counterintuitive. So what would you guys suggest as far as bandaging either one of these? And about one of the other questions that comes up too is on the abscess on the left under the breast, that the skin is kind of sloughing off. And if you can talk a little bit about that, because that's a common question that comes up, if that's from the inflammation or what's happening with the skin there. So Dr. LevTov, we'll start with you, and then Katie after that.
Yeah. So, I mean, a couple of things. Remember, this is all done in the context of, because we don't see frank ulceration here usually, but this is all done in the context of good medical care. So make sure that if this is recurrent, you got to talk to your doctor. And specifically here, because, sometimes an intralesional canalog can kind of stop this whole thing and make it go away. Those are the ones that are really good for that. Generally speaking, and that's, I think, my approach, and I think the recommendation now is when you see an abscess like that, to really try to use a warm compress, not inject first, try to let it kind of break down on its own. As I mentioned in my talk, I've got some good response about people using hydrogel dressing, so that's a different category. The hydrogel dressing or hydrogel in general is very soothing. It is not absorptive, so it's not something you would use to capture a lot of fluid coming out of the wound. But in the initial stages, if you have a few of those in your cabinet, then before this whole thing starts to break down, just applying it on can really be nice, calming, and soothing.
Is the hydrogel that you talked about the same thing as hydrocolloid?
No.
Okay.
So hydrocolloid dressings are different. The reason they weren't mentioned here is because I don't really use them a lot in HS. They don't have good absorptive capacity. They're excellent dressings, wrong disease.
Okay.
Yeah, and I second that as well. I did see a question about hydrocolloid, but it's not a dressing I think of in this condition either. So if whoever posts that has a specific indication that whether they've used it or why it was suggested to them, but in general,
Okay, perfect. And then Katie, do you have anything to add as far as these two abscesses to what Dr. LevTov had suggested?
Just by, reinforcing those basic concepts of like, okay, if this is swollen and painful, then just reducing friction, using a soothing topical that, for some people that might be hydrogel. I like that idea. Again, it's fairly accessible, fairly inexpensive. I've had patients where I say, okay, put it in the fridge, keep it in the fridge. Cause that, like I do with burn patients, like it's cooling, it's soothing in that way. And there's no limitation on how often they can apply it. If they're looking for more of a barrier, then I tend to recommend a zinc component, or calamine.
Okay, perfect.
All right, here comes Brinley. Here comes the list. Ready? You got your pen? Here it comes. All right.
Okay.
So we talked about contact layers. Those are the inert meshes that sit on top of the wound. Primary dressing. They're not absorptive. We talked about hydrogel just a second ago. Those are calming. They're not absorptive. Then you have the absorptive one. You have foams. I'm going to go from least absorptive to most. Okay. You have foams, most likely to be covered by insurance. Then you have the alginates. Those are the ones that can break down sometime, but they're very good absorptive. Then you have gelling fibers that are those fibers that gel and hold the fluid there. And then you have the super absorbent, kind of like this diaper technology. All right. So these are the categories. And if you speak that language, you got a heads up talking to your doc.
Perfect. And then we'll be sure to link that to, we'll put together a list as well based on all of that, just so that you can have that available to you. All right. And then we talked a little bit about this. Sometimes as an HS patient, you get really freaked out when you don't know what hypergranulation or proud flesh is. And we see this a lot in the support groups where the inside of your wound is kind of poking out. It's almost like it's reverse healing is what I always think of it as. So if you guys can kind of take us through hypergranulation, how you would address these. And again, all of this is not medical advice coming from these guys. These are really general guidelines that we're using because we do see all of these wounds very frequently in the HS community. So we're trying to give you kind of ways to deal with these on your own, but we do always recommend that you see a dermatologist or a wound care specialist if you have something that seems off or not right. So just to cover that. So Dr. LevTov, if you can start with these.
Yeah, so I'll briefly go. Really, the classic proud flesh hypergranulation is the top left, that red, beefy-looking wound that you can tell. How's the wound going to close if there's a mountain of redness in the middle? And so classically, your healthcare provider will probably use some method of getting rid of that. Silver nitrate is the most common one. It's easy. It's cheap. Basically, you apply it. It's going to slough off the next couple of days, and that's really good. I want to note that, especially here on the right, that not everything is as clear, and you need to see a dermatologist. So some of these things, this may be just proud flesh, but there is what we call a differential diagnosis, and you don't want to miss things. This can easily, not so many, but easily can be something else. So, I'm not going to name scary names. I just want to say that, some of these are not the classic appearance. And the point here is that these are things that are handled by a professional. So silver nitrate for those is one easy thing to do.
Yeah, I tend to, we are at a wound care center, so we have some topical products that we think about with these hypergranulated tissues. Definitely we use silver nitrate, but again, not going into that because it's not something you're going to do at home, but something you can talk to your provider about. But I tend to think about that biofilm, is there a bacterial burden, and are we getting adequate moisture management to help reduce that? And so sometimes I'll recommend, depending on, the level of comfort and pain level, increasing the frequency of washing and using an antimicrobial wash, and then using a topical antimicrobial, or changing up, the frequency of the dressing changes, or a more absorbent dressing.
Perfect. Yeah. And if you have wounds like this, again, it never hurts to ask your doctor for a referral to wound care as well. Wound care is an amazing thing. And I had no idea that there were so many products that were out there to help us until I actually went to wound care. So I would not be shy about asking your derm for a referral to wound care if you do have wounds that are not healing, or look somewhat like some of these wounds in particular. So and then, we kind of covered this one on the first, but we're left a lot of times with these holes that just don't seem to ever close up. Or sometimes they take years to close. What do you recommend for that kind of a wound or holes that will not close up?
So like everything in medicine, you want to investigate. So if you look at that picture on the left, apparently taken by my buddy Adam, a wonderful dermatologist, if you're in the DC area, you want to ask what's going on. So if you actually look into this, this is all, it looks like multiple wounds, but I bet you that this is all just one big wound under this with a little bit of roof of skin holding that is barely holding together. And so here, I've seen it go both ways. I've managed this medically after talking to the patient by giving them good HS treatments, whatever it is, and kind of supporting with good absorptive dressing, and this can get irritated with Exudate and all that. The other approach is cut it out, all right? So this is where you want to talk to your healthcare provider and say, this whole thing that you see all around, this whole thing just comes off, and that's it. So I've seen it work both ways, advantages, disadvantages, but talk to your healthcare provider. That will be my advice on that. Generally speaking, the other bottom line is if a wound doesn't heal, you need to ask your doctor why it's not healing. Generally speaking, it should heal if there's no obvious lesion there. For example, there was a question about that, about skin cancers arising in wounds and HS lesions. And it is true, generally speaking, about all wounds, not just HS. A chronic wound that stays for a long time can transform itself into a skin cancer. And so that's why it's very important to see someone who's well versed in those diagnoses. But with HS specifically, sometimes you are on immune suppressive or some other diseases that you may have as a comorbid conditions that can put you at risk for other conditions. So there's some overlap with a scary name called pyoderma gangrenosum. That's another wound, and you try to get it better and it just gets worse. So there's a lot of things to know, and you are the patient. Go to the professional, let them help you. A wound that doesn't heal is a reason to see a doctor.
Yeah.
Perfect. Katie, anything to add on that one?
No, 100%. I think when you have this degree of ulceration, the number one thing I can recommend is that you see a provider to help decide, make sure you're seeing a specialist, seeing a dermatologist at this point. And if you're not, getting into a dermatologist and a wound care center to help support you along the way.
And Dr. LevTov, the abscesses that we get that fill and drain and then fill and drain over and over that are the same ones, would you recommend de-roofing procedures for those?
Yeah, absolutely.
Okay.
I think those are great I see a lot of some of my female patients really, if it's just what you're getting, these little nodules and abscesses, they respond really well to hormonal therapy. Something like spironolactone is working really well for them. And then if it keeps coming, then you cut it out.
Okay, perfect. All right. And then these lovely yeast rashes that we get from drainage because it keeps everything really moist. We see this a lot in the community where people are asking questions about this. So what do you suggest for handling a yeast rash that comes up as far as treatment for those and preventing them from coming again?
I'll let Katie go first maybe this time.
I think this is just like a good segue into like talking about topical antimicrobials, topical antifungals, topical creams and ointments. And my overall recommendation is like there's in the pictures I'm seeing here, we often see like a comorbid or concomitant at the same time. So you see a bacterial burden and you see a fungal burden. And so it's common for us to recommend dual topical therapies, especially when we're seeing something like this. Those little red bumpies, we'll often put them on a topical antifungal. Those are generally just over the counter and usually respond pretty well. And we're wanting to dry the area out. So again, I have them start washing with a topical antimicrobial and then putting a topical antifungal, and sometimes that in combination with zinc to try and dry out the area. And additionally, clindamycin, metahoney, triple antibiotic versus bacitracin, those are questions that come up a lot for me. And I can just briefly go through my recommendations with regards to metahoney. The property of metahoney can be anti-inflammatory and antimicrobial, and there's some suggestion that maybe also antifungal. I'm not personally, anecdotally, again, there's not evidence to rely on this, but I don't personally recommend metahoney very often. I have a few patients that have tried it and they really like it, and it seems to reduce the inflammation for them. And I'm like, great, keep using it. But it's not my go-to. It's sticky. It's hard to apply. It actually can increase moisture in the area if it's already draining. So I don't know. Dr. LevTov might have a different. I think some people love metahoney, but
some people love it, and I think it's a wonderful product to have in your toolbox. But I agree, it's sometimes sticky and people don't like it. So if you like it, it works for you, go for it. And just make sure you don't take your kitchen honey and put it there. These are medical grade honey, meaning that there's no spores in it. Which is bad bacteria. So you just want to be careful using medical grade. Then the brands don't really matter, at least in my book. Excellent things. I think we see some growth here of Candida here in these pictures on the side. And I think actually the one on the bottom from Dr. Friedman is actually a great example of irritant contact dermatitis from a lot of exudation. So these are two different diagnoses, at least for me. One of the things that you want to help, I agree with what Katie said, keep things dry. You may want to get the antimicrobials the antifungal medication in a form of a powder. So those exist as well, miconazole powder and such. Those are available and easy to use and kind of help to keep things dry if they don't cake for you too much. The other product that I kind of like and get good feedback on is I'm going to mention a brand here. I'm sorry, I'm not affiliated with them, called InterDry. That is a sheet of cloth, kind of like an aluminum foil, basically. You pull it out and cut to size, and it's laced with silver. Remember, we talked about silver being an antimicrobial, antifungal. There may be also something like that with copper. I'm not sure if it's available on the market. Copper has very similar properties as well, probably better for antifungal. And so if you can get, there are now copper dressings on the market, but if you can get one of those, it's easy to use. Some of my patients just wash it, put it again. I don't recommend that because the manufacturer does not, but for them it works. So try at your own risk. But basically it's a cloth that you put under the folds, under the breast, under the panic, like the belly that kind of hangs over. You can put it right there where your belt goes. And it really is a great thing to reduce moisture, friction, and has antimicrobial effect all at the same time.
Yeah.
So when you talk about an antifungal, like if someone was going to try something over the counter to deal with a yeast infection at home, would that be like a Lotrimin kind of
Yeah,
antifungal? Or?
yeah. You can look at the on the in the pharmacy shelf, the antifungal creams, antifungal powders. Those can be useful. And if you're
Okay,
not sure, you can ask your doctor for a prescription.
perfect. Excellent. All right. And then last, we'll kind of wrap it up with some of the general questions that come up in that we see all the times in the group, in the community. Train of thought, we'll start with you, Katie, on air it out or cover it up.
That's a hard question to answer because it's like, again, this condition has such a spectrum. And so my general go-to with HS, again, because we're often in a management situation and not necessarily in a healing state, whereas some of the other wounds I treat, we're moving them into the healing state, and HS we're sometimes just trying to manage the inflammation or manage the drainage until we get to the next, whether it's surgical or medical management. So I tend to say do what feels comfortable, and we can help you find strategies to do that. Oftentimes patients feel with any kind of wound that they need to occlude that wound. They need to cover it up and put as much tape as they possibly can on it. And I kind of try to dissect that with them. Like, do you think that you're keeping bacteria out of this? Is it an odor issue? Is it a pain issue? Is it a drainage issue? And so we just try and figure out what their goals are and then meet the goal.
Yeah, and I think it does depend on each wound. And, we're kind of covering this from a really general, broad perspective. But yes, it definitely does depend on each wound. And then Dr. LevTov, what do you have to say about that?
Well, I'd say if there's an open wound, you want to cover it. So that's, there's, like Katie mentioned, there's a spectrum of different lesions, but classically speaking, an open wound will heal faster if it's covered. And so that's been shown over and over again. In HS, there is a challenge there in keeping it covered and keeping that whatever you're using on. But just purely speaking about how quickly the wound will heal, then keeping it covered will help.
And covered doesn't necessarily mean suffocated, correct?
No, absolutely not. It does not. No. So the dressings will provide some exchange of gases and stuff. Yeah.
Perfect. And then we kind of touched on Manuka honey. Sounds like based on you guys, it's a personal preference. If it works for you, great. Works for some, doesn't work for others. Sounds like most things when it comes to HS, kind of hit and miss.
And it's not a bad thing. It's just some people like it, some people hate it, and you got to find it. But there's no necessarily. I'll just say this: I think that medical grade honey is good, and that's it. It doesn't have to be from a particular island, from a particular plant, from a particular person. They seem to work the same. Perfect.
And then we kind of covered the hydrocolloid bandages that you guys said you wouldn't necessarily recommend for HS. That's been coming up quite a bit lately in the support group. So thank you for covering that. And then as far as Neosporin versus Vaseline, what would you recommend between those two? Are they equal? Is there a difference? Dr. LevTov, we'll start with you.
So they're not equal because Neosporin has antibiotics in it. Generally speaking, I want you to have a dressing on a wound, not just keep Vaseline. It's just not going to be good enough, or Neosporin. And in the sense of one thing you want to be cautious about is, are you allergic? Because then a lot of people are allergic to all the components in the antibiotic ointments. It could be the antibiotic itself. A lot of times, just the vehicle. So Vaseline or petrolatum jelly is really the cleanest thing you can do. So unless there's a specific reason to use antibiotic there, I don't really push for that. And so sometimes I know that in then dressing changes, it's recommended to use Vaseline and a non-adherent gauze on top. And so then I would go for that. I don't have a particular reason why to use antibiotic ointment specifically there. Now, if your healthcare provider in general said, hey, you can use something like clindamycin lotion, which is on our guidelines and such, then absolutely, that's a different story. But if you're just trying to find something over the counter to put on your wound, I don't even know that I would use Vaseline. I would use definitely a dressing. And if you're going to choose between these two, you probably just can do with Vaseline, which is cheaper anyway.
Perfect. Katie, anything to add on that?
Yeah, that's the same thing. I tell my patients there's probably no additional benefit to Neosporin and maybe more reactive. And so if, again, we're trying to find a product that is affordable and comfortable, helps release dressings, then Vaseline can be a pretty safe go-to. And again, it's just that component of soothing the skin and creating a barrier for that dressing so we can reduce adhesives if it's something we're incorporating.
Perfect. Next was options for adhesive other than tape, and I think we covered that earlier in the Q&A, and I think that the feminine hygiene products are amazing. We do see a lot of people recommending that, and it is not anything you would ever have assumed we would use that for, but hey, whatever works, right? And then the last question that we see is, what can you use zinc or diaper rash cream for when it comes to wounds? Katie, you want to start with that one?
I think we've kind of reviewed it. It's more to reduce friction and soothe the skin with moisture.
Yeah, exactly what Katie said. I think maybe a simple way to think about it is this is the stuff that will go around the wound, not inside the wound. This is to protect your skin from outside damages like friction, like a tape. So whatever comes into, like Katie covered it. Excellent. Before.
And does the percentage of zinc in that matter, or just any over-the-counter diaper rash cream would work?
It only matters to the extent like the higher your zinc concentrate, the thicker your paste is going to be.
Okay.
So if you don't want a really thick paste, then you get a lower concentration and it's going to be more creamy. If you want a really thick paste, then you do a higher concentration. Perfect. And Dr. LevTov, you can comment on this too. When patients have, again, because there's a spectrum of wounds that the patient could present with, but when they have these like multiple draining sinuses or they're these smaller sinus wounds, I tell them they can put the cream over. If a little bit gets on the open wound, it's not detrimental. When we have a large ulceration that we're trying to progress towards healing, we have a different approach. When you have these active draining sinuses, and then we tend to just focus on like reducing the pain, reducing the inflammation, figuring out what's comfortable. And it's okay if the Vaseline or the zinc comes in contact with those open areas.
Yeah, of course. Yeah, that's
perfect. We also at the bottom there put a link to, or the website address where you can go to see the wound care guide that we had put together. And it also has a link to the YouTube video that we had done as well. So hopefully you'll find that helpful. And this recording will also be available, I believe, within 24 hours of today. So if you need to rewatch it to catch anything, please do. I will talk with Lauren about how we can get all the information up, maybe on a discussion board with the links to the products or even just the list of names of them so that we can work that out for you guys. Thank you both so much. I really, really appreciate your time being here today. Thank you on behalf of all of the HS patients, Dr. LevTov, for everything that you do in the community and all of the research. And Katie, thank you for treating patients like me and like us. We appreciate all of the guidance and help that you give us in managing our own conditions. And thank you again, both. And I appreciate all your time. And we'll see you next time.
Thanks.
Thank you really for your leadership. Appreciate it.
Thanks.